This is Dr. Andrew Yudd over at St. John's Hospital in Santa Monica, and we wanted to take a few moments to answer the question of total knee replacement using RoboKnee, our robotic system. And we are often asked how we do knee replacement using RoboKnee, and there are really two answers to this. There's a simple answer and a more complicated answer. The simple answer is that we use anatomic balancing with robotic assist. But there's a more complicated answer involving the technical details of the procedure, the decisions we make in terms of millimeters, degrees, position, sizing, and alignment. This video specifically is for those who are interested in the more complex answer. We can't really use layman's terms in this video because we're dealing specifically with the technical issues of reformatting, placement, alignment, and sizing. So if you're just interested in the simple answer, do not take notes on this video. You don't even have to watch it. Again, this is specifically for those who are interested in the specific technical issues related to robotic knee replacement. And if that's you, sit back. We'll take you through an example of how we leverage and utilize this technology. Okay, so we'll start with the preoperative x-ray. This is an example of severe osteoarthritis. We call this Varus Deformity. In lay terms, this is bone on bone. The tibia is laterally subluxed. This is an unstable knee, and there is associated wear with bone loss on the tibial surface. When we look at the lateral side, we can see a significant amount of bone spurs, anterior, posterior, as well as loss of joint space in the patellofemoral joint. There is a lot of deformity in this knee and will require a lot of correction to reproduce a neutral and stable alignment. The first step in the surgical planning process starts with a CT scan. The CT scan does two main things. The first thing is that it identifies the mechanical alignment. So this patient has a bow-legged knee in relation to the center of the hip, the center of the knee, and the ankle. And so we want to determine ahead of time that relationship and that mechanical alignment so that we have a target for our mechanical correction. The CT also allows us to create a three-dimensional model of both the femur and the tibia so that we can appreciate in detail the amount of bone spurs, osteophytes, bone loss, and deformity. And this helps us identify bone that we need to maintain versus pathologic bone and areas of bone loss. Once we have established mechanical alignment using the hip, knee, and ankle centers, and we have established the 3D model, we will then use virtual planning for anatomic placement. We'll take a virtual model and overlay this onto the deformed femur and tibia. We use a component with a single radius of curvature of 8 millimeters of thickness. We then place this to reestablish the normal contours of femoral and tibial bone distally, anterior posteriorly, as well as medial laterally. We use the same amount of implant to restore the same amount of structure that will be resurfaced. With this plan in place, we then move to the operating room. We register the femur and the tibia and then download that information into the computer hardware system to match our preoperative plan. We will then get an initial assessment of the degree of deformity. In this specific situation, we see we have an 8-degree flexion contracture and 12 degrees of varus. We can see an extensive amount of lateral subluxation as well as medial tibial bone loss. There is a 9 millimeter asymmetry between the medial and lateral sides. We will then tension the knee back to the ideal length of the collateral ligaments. And we can see we have moved from a 9 millimeter T delta, or difference between the two sides, to a 3 millimeter difference. And so there's already been a 6 millimeter correction and we are starting to restore the symmetry between the femur and tibial alignment. We will then go through a similar process at 90 degrees of flexion. In this patient, at 90 degrees flexion, there is 8 degrees of varus, but most significantly, there is a 7 millimeter asymmetry between the medial and lateral sides. We will then intraoperatively tension the knee to correct this deformity to the ideal length of the collateral ligaments. And here we also have been able to correct to only a 3 millimeter difference between the two sides. We will then take this information that we received intraoperatively from dynamic balancing and then apply this to our anatomic planning page. Okay, and now that we have the dynamic balancing information and we have the anatomic plan from our preoperative stage, we will then merge the two to create precision in balancing. We'll first start an extension looking at the coronal plane of the femur. We will put 1.1 degree of varus and on the femur and 3 degrees of varus. This will correct our asymmetry of 3 millimeters in the extension gap. We'll then look at the axial view to correct the flexion deformity. So if we remember, we had 3 millimeters of asymmetry. We will externally rotate the femur 1.4 degrees to the posterior condylar axis. And then in order to maintain symmetry, we will flex the femur to 6 degrees to maintain medial lateral sizing and anterior posterior to make sure that the anterior flange is flush with the anterior cortex of the femur. Once we are balanced, we will then go through a series of checks looking at each stage and each anatomic landmark. So in this specific part, we will look at the anterior flange to make sure that there is no notching and to make sure that the anterior cortex is flush. And you can see we have a large posterior osteophyte, which could, in the absence of a CT, lead to a miscut or oversizing of the implant. We will then look at the posterior aspect of the femur to make sure that we have maintained the appropriate radius of curvature and the appropriate amount of offset. We can also appreciate in this view the osteophyte, which will need to be removed to maximize full extension in the patient. We will then go to a sagittal view of the tibia to look at depth. We knew that there was medial wear, but we can see when we look at it from a sagittal section, the implant is fully rested on bone. It's appropriately sized medially and laterally. You can see the anterior bone here and the posterior bone here are osteophytes. These are fake outs. Knowing that these are osteophytes help us to appropriately size the dimension. We then look at the same image on the lateral side. You can see here we are able to reproduce the same amount of tibial structure using that implant. We then move to the coronal cut of the femur. We will place a virtual implant. This allows us to see before we made any surgical decisions or surgical action that we have been able to reproduce the normal contour of the distal femur. It also allows us to see ahead of time the appropriate amount of rotation has been placed, and this can be confirmed by looking at this piano sign on the anterior cortex of the femur. We then look at our middle screen, as seen here, and we are looking at 3 different aspects. The first thing that we will do is we will look at the relationship between the trochlea or the patellar groove of the implant in relation to the patella groove of the real femur. And we can see that we're not overstuffed and that we are tracking the patella groove. We then scroll further down, and then on this one we are looking specifically at medial lateral sizing to make sure that we have the appropriate fit. We've already confirmed this, our anatomic planning. This is another secondary check to make sure that we have the right size as well as medial lateral placement of the femoral component. Our third check is looking at the axial femur, specifically at femoral rotation. Now, we already had an idea of the proper amount of rotation being placed by the restoration of our flexion gap as well as the anterior cortical piano sign, but we will also look on this view at the posterior condylar axis as well as the surgical epicondylar axis and ensure that the position and rotation of our femoral component is parallel to this. Once we have confirmed this, we will then proceed with our resections and balancing. With the implants in place, we can see we will then go through a secondary set of checks using an insole technique looking at flexion, extension, gap balancing. And you can see with the implants in place, we've made several corrections. First that we can see is we've corrected our flexion contracture. We can also see that we've corrected the original Varus deformity down to 4 degrees. Most importantly, we now have a symmetric extension gap of 19 millimeters on both sides. We will then go through the same process intraoperatively in the flex position. At 90 degrees, we can see that we have corrected the original amount of pathologic varus. And then most importantly, we have corrected the asymmetry, and we now have 19 millimeters on both sides. So now the medial side is symmetric to the lateral side, and this flexion gap is now symmetric to the extension gap. We confirm this clinically through range of motion testing in surgery. Postoperatively, we can see the results of our work. We can see how we've gone from an unstable, unbalanced knee to a stable, balanced, well-fixed knee as seen postoperatively. The RoboKnee has given us a tremendous amount of ability to correct any type of deformity with precision. The nice thing is that we are able to understand alignment, deformity, osteophytes, the difference between pathologic versus normal bone, sizing, and positioning all ahead of time. Then we also have the ability to make intraoperative fine-tuning adjustments to restore precise balance. And at the end, we're able to confirm that we have a stable, well-balanced knee. Thank you very much.